Varicose veins. Varicose veins or varicositis are dilated, tortuous subcutaneous vein most frequently found in the saphenous system. They may be small and innocuous or large and bulgy. Primary varicose veins, which are more common in women and patients with a strong family history, are probably caused by congenital weakness of the vein. Secondary varicose veins typically result from a previous DVT. DVT means deep vein thrombosis or another identifiable obstruction. Secondary varicose veins may also occur in the esophagus that we call esophageal varices. In the anorectal area, hemorrhoids and as abnormal arteriovenous connection. Reticular veins are small varicose veins that appear flat and blue-green in color. Etiology and pathophysiology. The etiology of varicose vein is unknown. Superficial veins in the lower extremities become dilated and torsos with increased venous pressure. Risk factors for varicose veins include congenital weakness of the vein structure, female gender, use of hormones, increased age. Use of hormones, that means oral contraceptives or hormonal replacement therapies, increasing age, obesity, pregnancy, venous obstruction resulting from thrombosis or eccentric pressure by tumor, or occupation that require prolonged standing. As the vein enlarge, the valve are stretched and become incompetent, allowing venous blood flow to be reversed. As back pressure increases and the calf muscle pump fail, further venous distension results. The increased venous pressure is transmitted to the capillary bed and edema develops. Clinical manifestations and complications of varicose vein. Discomfort from varicose veins varies dramatically among people and tends to be worsened by superficial thrombophlebitis. In addition, many patients voice concern about cosmetic disfigurement. The most common symptoms of varicose veins is an ache or pain after prolonged standing, which is revealed by walking or by elevating the limb. Some patients feel pressure or a cramp like sensation in the legs. Swelling may accompany the discomfort. Nocturnal leg pain in the calf may occur. Superficial thrombophlebitis is the most frequent complication of varicose vein and may occur either spontaneously or after trauma, surgical procedure, or pregnancy. Rare complications include rupture of the varicose vein from weakening of the vessel wall and ulceration of the skin. Diagnostic studies and collaborative care. Superficial varicose veins can be diagnosed by appearance. A duplex ultrasound can detect obstruction and reflex in the venous system with considerable accuracy. It is the most widely used test to diagnose deep varicose veins. Treatment usually is not indicated if varicose veins are only a cosmetic problem. If incompetency of venous system develop, collaborative care involve rest with the affected limb elevated, compression stockings and exercise such as walking, and herbal therapy used for the treatment of varicose veins in horse chestnut seed extract. Sclerotherapy involves the injection of a substance that obliterates venous telangiectasis, that means spider vein, reticular vein, and small superficial veins. Two sclerotherapy techniques are available: injections of a sclerosing agent alone or injection of a mixture containing a sclerosing and foaming agent. Commonly used sclerosing agents include hypertonic saline, saline plus hypertonic dextrose, and ethanolamine oxalate. Direct IV injections of a sclerosing agents includes inflammation and result eventual thrombosis of the vein. This procedure can be performed safely in an office setting and cause minimal discomfort. Potential complications include itching, pain, blistering, edema, hyperpigmentation, necrosis, superficial thrombophlebitis, and deep vein thrombosis. After injection, the leg is warped with an elastic bandage for 24 to 72 hours to maintain pressure over the vein. After removal of the elastic bandage, compression stockings are recommended for 2 to 3 weeks to minimize complications. Long-term compression therapy is advised to help prevent the development of further varicositis. Newer, more costly but non-invasive options for the treatment of venous telangiectasis include laser therapy and high-intensity pulsed light therapy. Laser or light therapy is indicated for isolated small telangiectasis or for patients in whom sclerotherapy is contraindicated or has been previously ineffective. Laser treatment typically require more than one session, scheduled at 6 to 12 weeks interval. Vascular laser work by heating the hemoglobin in the vessels, which injures the endothelium resulting in vessel sclerosis. Pulsed light therapy is similar to laser therapy but uses a spectrum of light rather than a single wavelength. Potential complications associated with both these therapies include pain, blistering, hyperpigmentation, and superficial erosion. Surgical intervention is indicated for recurrent thrombophlebitis or when CVI cannot be controlled with the conservative therapy. The traditional surgical intervention involves ligation of entire vein and the dissection and removal of its incompetent tributaries. An alternative but time consuming technique is ambulatory phlebectomy, which involves pulling the varicosity through a stab incision followed by excision of the vein. Newer, less invasive procedures include endovenous occlusion using radiofrequency closure or laser, or trans-illuminated powered phlebectomy. Both method of endovenous occlusion involves application of local heat to obliterate the lumen of the targeted vessel. Endovenous occlusion may also to be done in combination with the saphenofemoral ligation. Prevention is a key factor related to varicose veins. The nurse should instruct the patient to avoid sitting or standing for long periods of time. Maintain ideal body weight. Take precaution against injury to the extremities. Avoid wearing constrictive clothing and participate in daily walking program. After vein ligation surgery, the nurse should encourage deep breathing exercise which help promote venous return to the right side of the heart. The extremities should be checked regularly for color movement, sensation, temperature, presence of edema, and pedal pulses. Bruising and discoloration are considered normal. Postoperatively, the legs are elevated at a 15-degree angle to prevent edema. Compression stockings are applied and removed every 8 hours for short period and then reapplied. Long-term management of varicose vein is directed toward improving circulation, relieving discomfort, improving cosmetic appearance, and avoiding complications such as superficial thrombophlebitis and ulceration. Varicose veins can recur in other veins after vein ligation. The patient should be taught proper care of the lower extremity, including cleanliness and the use of individually fitted compression stockings. The patient should be taught to put on the stockings while still lying down just before rising in the morning. The importance of periodic positions of the leg above the heart should be stressed. The overweight patient may need assistance with a weight reduction. The patients with an occupation that require prolonged period of standing or sitting need to change position frequently.